Hi, I'm Neha and this is The Coffee Table, and today we are going to be talking about something that's very close to my heart. We're going to be talking about pregnancies and the various complications pre, intra, and postpartum that pregnant women face. Childbirth is still, I feel, the great sort of unknown. And all sorts of things can happen during the process. And just because so many women around the world are able to successfully have babies and come out of it alive and healthy doesn't mean that A, it's not incredibly dangerous, B, they don't need support and monitoring throughout the process, and C, what do we need to be looking at specifically in this region where there is so much income inequality, where malnourishment is already an issue that so many expectant mothers face, and so many more things. And I'm so excited today to be welcoming two incredibly inspiring women onto the show to sort of tell us more about various pregnancy complications and what can be done to address them, to prevent them, and to treat them. We are delighted to be welcoming on the show today Neha Mankani, who is a midwife and a public health practitioner. She is the founder of the Mama Baby Fund, which is a financial emergency fund for maternal and neonatal health. She works with the Global Health Directorate of the Indus Hospital, where she set up the midwifery and maternal health programs at various Indus Hospital primary care sites. And we are also joined by Dr. Shahnaz Nawaz, who is the Associate Chief of Obstetrics and Gynecologist at Shifa International Hospital, where she is also a consultant OBGYN. And see how I skipped saying obstetrics more than once. Welcome to the show, ladies. It's lovely to have you here. And although this is, I feel, a really sort of somber topic, they are also, if I understand it correctly, Dr. Shahnaz, a lot of pregnancy complications before pregnancy and during a pregnancy are often ones that are preventable. Is that true?
Well, you're right. A lot of them are preventable. That's why it's very important for us as clinicians and our midwifery colleagues and other healthcare professionals to optimize women's health and make sure that they are in their A1 condition before they conceive, and then when they conceive, they're given appropriate health care, and at the time of labor, trained staff is available for delivery for the mother and for the immediate care of the neonate. So because a lot of problems do occur which are actually preventable, and this is the tragedy of the world. And I have to say that there are these problems do take place in the Western world and on a much larger scale in our country.
Yes.
The care system is rather sketchy. There is maybe urbanized, cities have hospitals and healthcare facilities where if you go to far-flung areas, there is scarcity of this kind of service. So yes, you're absolutely right. A lot of these problems and complications are preventable.
But it's interesting because I'm glad you mentioned it, that it sounds like it's a sort of multi-step process, that you need to be looking at the health of a woman before she conceives, and then it has to be looked after during the pregnancy, and then labor is a whole kind of situation in itself, where then you are looking at the process, you're looking at the sort of the trauma to the body, but you're also looking at the health and the well-being of the neonate, which is like the little newborn, the baby. So that to me implies that a safe pregnancy is one which is planned. Well, if you are planning it, then you can make sure that you are taking your supplements or taking your folic acid, or you're getting your blood tests, or you're looking at your family history.
Absolutely. You see, you mentioned folic acid, so I'll start off with folic acid. So this is folic acid is actually a vitamin. It's available in our diet, but it is it's not. There is a little bit of deficiency in our diet, and because we don't take a lot of greens, and so it is deficient.
Yeah.
So by taking folic acid pre-pregnancy, one can prevent a congenital abnormality called neural tube defect, whereby babies whereby babies can develop problems in their spinal cords, in their brains, and so in fact, this is the only preventable condition called neural tube defect, which you can prevent by taking folic acid before pregnancy and during the first 12 weeks of pregnancy. So so and to optimize a woman's health, you see in our society, in Asian women, diabetes is very prevalent.
Yes.
So if a woman's diabetes is uncontrolled, and very, very few people know that a very high blood sugar level is a teratogen. So teratogen, in other words, mean that that it is a substance which can cause congenital abnormality in the baby.
Wow.
So if the if a woman's blood sugar levels are not optimized before pregnancy, then they run a risk of having a baby with congenital abnormalities, and they can run a risk of having miscarriage, and then they run a risk of having problems at the time of delivery, because these babies are rather bulky. They're big babies, and during the time of delivery, they'll have problems. So these are the kind of things that one. And similarly, blood pressure. So if a woman has a blood pressure, it needs to be optimized, and the patient needs to be on the right antihypertensive medication.
Yes, absolutely. So, and blood pressure is extremely important. I'll come back to it in just a second. But hi, Neha, can you hear me?
Yes.
Hello, welcome to the show. It's so nice to have you back. I was reading with statistics at the Fistula Foundation, and according to them, in less than 6 out of 10 women in Asian and African countries give birth without medical professionals present. And I know that with your work with the Indus Hospital and as a midwife, you deal with a lot of women for whom that kind of healthcare and medical attention during their pregnancies and even after is at best, like Dr. Shahnaz said, it's patchy. And then it's unreliable. And there's so many women who, because it sounds like, I feel like we operate often on this idea that, well, so many women have babies. So, you can just have one too. And then a lot of women do, but it can also, there are so many things that go into not just a healthy baby, but also a healthy mother. I think we often tend to focus on healthy babies and sort of throw the moms out with the bathwater.
Yes, absolutely. So this is, this 60 less than, this is what we're seeing in Pakistan as well. Around 4 in 10 women will give birth at home. And these are official statistics. I actually think that the numbers are much higher than that. I think deliveries with unskilled birth attendants are much higher than that. Lots of people give birth at home. And if they don't give, and we're just counting people who give birth at home, we also have a lot of skilled birth attendants or, providers at small facilities who may count as a healthcare provider, but are not necessarily a healthcare provider. So a lot of times we'll also see that, the number that's counted as a skilled birth attendant is not necessarily a skilled birth attendant. So we'll always count the people who give birth with traditional birth attendants, DIs, as the unskilled, but a lot of people, the access that they have to skilled healthcare providers are not necessarily trained professionals. So, you'll see in a lot of places that their clinics, you'll see clinics where women are sitting saying that I'm a doctor, but she might just be a lady health worker, or, she might be doing a C-section even though she's a midwife. So there's also a lot of, or even if she's doing a delivery, she might just be a badly trained professional, like, a midwife who passed an exam just by kind of just getting a certificate. So I also think that those providers are also contributing to a large amount of unskilled birth. And fistulas are absolutely one of those things that happen as a result of a bunch of things. One of them is, early age marriage, in which an underdeveloped pelvis is not ready to give birth. Yes. Or just obstructed labor, where the woman has just been in labor for too long and she's not able to progress, tissue necrotizes. So I think that you're right. I feel like a lot of people just don't have access to the healthcare provision that's required to have a safe birth.
Yeah. I'm glad that you brought up age girls having babies. So technically, what is an appropriate baseline age for a young woman to get pregnant?
So the minimum, I would not even say. I think minimum it's considered to be at least the marriage age, legal age of marriage, which is around 18.
Yes.
But I don't think that anyone is physically ready to give birth at least till they're 21 when their body is ready. And then we also look at look at emotional readiness and financial readiness, because that also contributes to things like, we'll see women who come, young women, in my experience in antenatal clinics, also have a lot less autonomy over their bodies. So they also cannot make decisions around seeking healthcare. They're not given that kind of importance that an older woman might be able to plan her pregnancies better. She will be able to decide whether she can go to a doctor or not, or, whether she can access, she may have a little bit more financial autonomy to purchase medicines or skilled healthcare. So that also kind of comes with it,
No, absolutely. And Dr. Shahnaz also feel that a lot of pregnancies are unplanned, at least in Pakistan. And have you seen that sort of clinically? Because now, again, I'm thinking about when we plan a pregnancy, then we're able to kind of get all our ducks in a row in terms of healthcare. But if it's unplanned, and then an unplanned pregnancy is also the result of a lot of people are nervous about contraception, a lot of people don't want to talk about it, a lot of people are afraid of taking it, afraid of practicing it. So there's a lot of sort of medical, cultural clashes happening here as well.
Yeah, a significant proportion of women do have unplanned pregnancy, and I totally, will agree with you in this sense that contraception is not very much talked about, even in our profession. And I'm surprised to see that even gynecologists are a bit, they're shy or a bit loath to, talk about that. I don't know why there is this thing about contraception. So so this is something that when I was training and in Pakistan and for my postgraduate training, this was a must discussion after every delivery. In fact, it used to start during the antenatal period.
Yes.
But yes, I see a lot of women, a lot of antenatal women, a significant proportion of them, they have unplanned pregnancy. But then not only that, I also find that there is some social and family pressure on women to produce more.
Yes.
And that is also kind of a forced pregnancy, if I may use this term.
Yes.
Because this is the women's willingness is kind of not counted
taken into account. Absolutely.
Is yes, and so it is just under social pressures and family pressures. They're
absolutely,
they're supposed
and
to
then
produce more.
And like Neha, if you throw into the mix somebody who's just not old enough to have that emotional maturity or autonomy over their own body, then you're looking at a really, really risky situation to put any young person into. We're going to take a very quick break. At this juncture, we'll be back in a flash. Stay with us. Hi, and welcome back to the coffee table, where we are having a fascinating conversation about pregnancy and safety for pregnant women pre and during, intra and postpartum. And we are in conversation with midwife and public health practitioner Neha Mankani and consultant obstetrician and gynecologist Dr. Shahnaz Nawaz. This is like a personal tongue twister, obstetrician. So before the break, I have been sort of wittering on about why it is so crucial for women who want to get pregnant or are getting pregnant willy-nilly to be of age to do it. And the reason for that is, during the course of my research for this show, so many pregnancy complications happen because women's bodies are just not developed enough. And one of those complications include pregnancy-induced hypertension disorders. And Dr. Shahnaz, you briefly sort of mentioned blood pressure in the first segment. So tell me a little bit about what role blood pressure plays when it comes to pregnancy.
So there is a condition called pregnancy-induced hypertension, which about 6 to 10% of women have this complication during pregnancy. Now, why it happens in some women and not in others is still not known.
Right.
It seems to be a multi-system organ illness whereby the blood vessels kind of go into spasm, the blood pressure goes up, the blood supply to the babies is reduced. So we tend to have smaller babies, or sometimes the babies die in the mother's womb. We find that in severe cases, women can develop fits, and even more severe cases, we can develop hemorrhages in the brain, and it can even cause death. So it is a pretty scary and serious condition, not only for the mother, but for her newborn baby.
For her baby
so
as well.
For the baby as well, for her unborn baby.
And what's kind of alarming is that, like that you said, that there's no real reason why it happens. So you don't necessarily have to be somebody with a history of high blood pressure to develop this during a pregnancy.
So there are certain risk factors. So one of the risk factors is women with prior history of high blood pressure. It tends to occur more in women in their first pregnancy, and women who have a family history of pregnancy-induced hypertension. So if their mothers and sisters have had pregnancy-induced hypertension, so they run a risk of having it in their pregnancy. And then there are certain medical conditions like diabetes, pre-existing diabetes, and certain immunological autoimmune conditions like antiphospholipid syndrome. So these are the conditions. Kidney disease is another very strong risk factor for pregnancy-induced hypertension. So but in some cases there's no risk factors, and yet women suffer this condition.
It just happens. So Neha, how does one diagnose this kind of hypertension? Is it just literally just you take somebody's blood pressure and it's high and it remains high throughout their pregnancy?
No, so it's not. There are different levels of measurement. So women so if I'm calling it pregnancy-induced hypertension, I will, it usually will come after the 20th week of pregnancy. So that's around when you'll start seeing it. And then we look at the readings, if there are different levels, like if it's above 98 by 140, it's above that. And it's consistently over a number of readings, it's above that. And then we'd also check the woman's urine, and if there's protein in the urine, then we'll say that we can make a diagnosis of pregnancy-induced hypertension, or if we're going towards preeclampsia. So there are a number of blood tests and other tests that keep happening throughout pregnancy to see where it is and what's going on with it. And you can also have just women who have hypertensive disorders prior to pregnancy who either turn into pregnancy-induced hypertension in their pregnancy, or they just continue with that, but then they won't have any proteinuria.
Oh, okay. So does a pregnancy-induced hypertension go away once you've delivered the baby, or do some women still have it afterwards?
It is there in the postpartum period as well. I've personally seen women who have had an eclamptic fit maybe third or fourth day postpartum, because it takes a while for it to settle. So, and I'm sure Dr. Shahnaz can add to this also, and for many women it means that they will continue to have issues postpartum as well. Sometimes it turns into cardiac issues later. And for other women, it'll just resolve after their pregnancy hormones have settled.
So it's variable. If you fall into the category that needs monitoring, then it's important to realize that if you've had pregnancy-induced hypertension, you need somebody to be monitoring you for at least several weeks of postpartum.
Yes, I would say that to all women under my care who I've seen have pregnancy-induced hypertension. I would monitor them quite closely in the postpartum period, which is usually a challenge. And again, I'm sure Dr. Shahnaz agrees that losing women in the postpartum period is very common. And by loss, I mean not that we lose them, but they just don't. It's hard for women to come back for postnatal visits.
For a second, you had me there. For a second, I was just like, oh, what? So what you mean is that once they've had the baby, then it's hard for them to come back to the clinic because now the baby is born, and now what's the need?
So you have to take care of the baby, and moving around, being mobile with the baby is difficult. It's okay to access care while you're pregnant, but you don't necessarily need to access it after you've given birth. So I think that monitoring will often really go down in the postnatal period.
And I'm glad that you mentioned preeclampsia, because I think that's the condition that is the most sort of well recognized, at least. So Dr. Shahnaz, could you tell me, what is preeclampsia one of the various hypertensive disorders that one can have when you're pregnant, and what happens with preeclampsia?
So essentially, women can have just high blood pressure in pregnancy and could be controlled with antihypertensive medication. But it converts to preeclampsia, and then when the danger bit starts,
right,
that's when women start losing proteins in their urine, and they are at a much higher risk of developing fits and brain hemorrhage, and so preeclampsia. And then there are certain features within the body that change. For instance, they may drop their platelets, their uric acid may go up, their coagulation profile may get deranged, their liver function may get impaired. So there are so many things that it's a multi-system, multi-organ problem.
Right.
So that's when the danger starts. If a woman has high blood pressure and one can control it with the antihypertensive medication without having the further complication of preeclampsia, then it's not too bad. But only when the preeclampsia sets in, then the alarm bells start to ring.
Right, and then that's when you've reached an emergency situation. So Neha, if one has hypertension but it isn't treated, then clearly it's incredibly dangerous for a pregnant woman. Is it possible to sort of deliver safely without this condition being managed? Because I am again thinking of sketchy or patchy or just incomplete access to healthcare for so many women. And what happens?
It is possible to deliver safely, but it depends on how much it progresses. So if it becomes preeclampsia and the woman any medication, and there's a very chance that it will turn into eclampsia, we'll see a lot of women who come into our midwife labor rooms in these rural areas, and a lot of them have not had access to any antenatal care, so we don't know that they have hypertensive disorders. So a lot of them, the first time we see them is when they come in to give birth, and as per policy, you can't actually turn away. Technically, we don't take women who we haven't seen in the antenatal period, but we can't turn them away if they come to us in labor. And so when it's not managed, especially during the intrapartum period when women are giving birth, your system is in overdrive. So that is when we'll see their blood pressure skyrocket. A lot of times right after they give birth, they'll have an eclamptic fit, or we'll just see something like, we didn't know that they had hypertensive disorders after they gave birth. Like how Dr. Shahnaz mentioned, sometimes it'll become DIC, it'll become a clotting disorder, and we'll just see them bleed out. So when it's not managed, it can, if it's a mild form, of course, you could potentially give birth safely, but there's a very big chance that you wouldn't give birth safely.
On that very serious note, I'm going to take a very quick break and be back in just 1 second. Stay with us. Welcome back to the coffee table, where we are having such a really, really important, urgent, crucial conversation about anti and intra and postpartum health and safety with midwife and public health practitioner Neha Mankani and consultant obstetrician and gynecologist Dr. Shahnaz Nawaz. Third time's the charm. So Neha, before the break, we were talking about pregnancy-induced hypertensive disorders and how it can be incredibly dangerous for women. But another sort of really, and I'm glad that you mentioned it, you talked about intrapartum time, which is basically the process of being in labor. And there are lots of things that can happen during labor also, which can pose a lot of issues and maybe even some sort of unanticipated issues. And I do understand that one problem is a prolonged labor. So usually, what's a normal labor time?
So there's no, I wouldn't say that there's a specific time that in which a baby needs to come out, or that there's in which a labor must finish. But there are rates of progression that we would see. So when a woman is in active labor, we'd say that she should dilate around 1 or 2 centimeters per hour. And when her baby is like crowning, then she should give birth within 2 hours. And we'll use tools to look at it. So we'll look at how much she's dilating, how long it's been, how long her water has been burst, and how her baby is doing. So there's there's intrapartum surveillance that also indicates whether the baby is okay, and it can stay inside for a little while more. So, and prolonged labor is where we've assessed a woman, she's at a certain level, and you'll check again in a while, and the progress that you hope to see, you're not seeing it. And she's kind of stopped dilating, or she's dilating very, very slowly, and the baby is in trouble. So we'd say that, the labor has become prolonged and you need to take action.
So what are that can happen if a labor is prolonged, and either it's sort of nobody knows what to do about it, like we said previously in the first segment about how a lot of women give birth without a skilled or a qualified medical practitioner with them. So if you are alone, or if you're at home and you're just giving birth, sort of winging it, then you don't know, how do you manage a prolonged labor? And what can happen if you don't?
At home, a lot of births are not, the traditional birth attendants or your neighbor, whoever's helping you, is not managing the prolonged labor because they're not aware that it's a prolonged labor.
Yes, exactly.
And they also don't, and often that, this is something that happens to us at our midwife-led units or in some of the more remote areas where we work, that the time when you take action to the time where you get to a referral facility is quite long. So it's not as simple as, you'd get an ambulance and be there. And in Western countries, you'll see that if a midwife does a delivery, she needs to have a referral point 10 minutes away from her. But for us, sometimes that means 75 minutes in some of, one of the sites that I do antenatal clinic right now, which is an island. It means that they would get into a boat. You'd take a boat, a 15-minute boat, then you'd find some kind of transport. If there's high tide, if it's the summer, it would take longer to find a boat. You'd get into town, then you'd get a rickshaw, then you'd get to the facility, and that would take a really long time. So, and for the dai to reach that point where she says that this is prolonged labor and I can't manage it anymore, so a lot of things can happen. If the baby goes into distress, the baby can pass meconium, which can, if the baby aspirates meconium, it can be fatal for the baby. It can it's prolonged obstructed labor, which is not managed, as you mentioned earlier, can lead to obstetric fistulas. We're seeing that a baby who has a prolonged second stage sometimes will come out asphyxiated, which means that often either the baby, because it's had respiratory distress, it will not survive, or sometimes survives with very serious morbidities like cerebral palsy or other issues. So it can be disastrous for the mother, it can be disastrous for the baby, it can be disastrous for both of them.
Yeah, and sort of in a long, very serious lifelong impact as well, even if you do survive it with a lot of morbidities. And wow. It's just really hats off to women, to women like both of you, my wonderful guests, who are dealing with stuff like this every single day and making it safer for women across this country. So Dr. Shahnaz, tell me, there's also obstructed labor, and I imagine that that's different from prolonged labor, and then also a lot of prolonged or obstructed. So what happens with an obstructed labor? What's that?
Obstructed labor is so if the labor gets too prolonged, so it's not coming down. So there are reasons. There are maternal causes of obstructed labor or fetal causes. So if the mother's pelvis is too small for the size of the baby, what we call is cephalopelvic disproportion, or if she's undernourished, if she's malnourished, so her bones are not well formed, and she cannot, the passage for the baby is inadequate, and yet so the delivery does not take place. Then there are fetal causes. So if the baby is too big, and babies are bigger because of diabetes, the changing dietary habits of women, and so that's why babies are now bigger in some cases, but the pelvis remains the same size. So then there is an obstruction.
Yeah.
Now, typically in a healthcare facility, we are not seeing too many obstructed labors.
Because I'm curious about fistulas that Neha also mentioned, and that fistulas, two very common reasons for fistulas are a sort of inadequately formed pelvis, which happens usually because the mother is just not, her body isn't developed enough to be pregnant and to be giving birth. And if they're malnourished, then that's also something that's very common in areas such as, South Asia and a lot of African countries where there is malnourishment. Malnourishment is worse in girls and women in any case because of a lot of cultural reasons as well. So we're looking, I imagine that indicates a fairly high prevalence of fistulas in these regions.
So what happens that the women who deliver in far-flung areas where there is scarcity of trained healthcare professionals, midwives, dyes, etc. And even if they don't have access to delivery of obstructed labor, women with prolonged labor. So prolonged labor culminates into obstructed labor. Obstructed labor essentially causes fistula because there is the head of the baby, and there's the bladder here. It's trying to go into the into the pelvis. Here's the bladder wall, and it gets compressed against the bladder wall and the pubic bone. The bladder is in between the baby's head and the pubic bone. It gets crushed, and there is no blood supply to the bladder. When there's no blood supply to the bladder, there's necrosis of that area.
Yes, which means the tissue dies.
The tissue dies. The tissue dies. There is leakage of urine. They develop fistulas. Not only labor has other consequences, as Neha mentioned. The baby in a prolonged labor develops hypoxia, meaning that the oxygen supply to the baby's brain is reduced, which can cause cerebral palsy and even.
And I find fistulas horrifying because, again, I was looking at statistics, and most fistulas happen to younger mothers because of the underdevelopment of their body, and it happens in first pregnancies. So if on average, if you're in, let's say, your late teens or early 20s when you're having this first baby and you develop a fistula, you can spend the rest of your life having no control over your bowel and often your intestines. So you're sort of leaking urine or feces almost your entire life, and that is horrifying to me. So Neha, do you think that the way a lot of times to deal with these various challenges that we're having with prolonged labor, obstructed labor, then C-sections are sort of an effective way to manage this? Because I do know that you have some thoughts about, let's say, placenta accreta, for example, and a lot of C-section procedures that, I don't know, you have thoughts on this, and I want to know them.
Absolutely. So I have thoughts on this because I think I do see in a lot of places in Pakistan, you'll see whether this is, hospitals that are underserved or in areas where they have, high resource hospitals. I think, yes, C-sections are overprescribed, and the C-section rate in Pakistan, around the world, technically should never be more than 15%. In Pakistan, it's much higher. And most hospitals will say that their C-section rate is around 45%, 50%, 60%. And that means, and because we work with midwives, we also see that they're able to deliver a lot of babies safely who have come from places where they've been told that they can't be delivered safely. So yes, overprescription of C-sections is absolutely a thing. C-sections are a way to safely deliver babies, and they have been around for many years. So babies who are in trouble, babies who have meconium issues, who maybe have a cord around their neck, which is causing asphyxia, or they're not descending, or something happens to the mother intrapartum, blood pressure issues, or baby is breech or malposition, though the baby does need to be removed by C-section, absolutely. But I think there's also overprescription in cases where you'll say that, the doctor is only available at this time, there's no doctor at night, we do the C-section in the day, or, I've seen I've been at facilities where I've seen doctors tell women that, I've checked your blood pressure once, it seemed a little high, now C-section is the only way to do it. So
Right.
there are a lot of reasons that C-sections are overprescribed, which does lead to disastrous consequences. That one of them is placenta accreta, which we've started seeing a lot of because, and accreta is not only caused by recurrent C-sections, but but when there is scar tissue in the uterus after recurrent C-sections, and especially ones that are not done properly, it can lead to placenta accreta, which is a very disastrous outcome. And then I'm also seeing in a lot of places a lot of wound issues. So Mama Baby Fund sees a lot of women who come in from, they've had C-sections in places where maybe someone who wasn't qualified to do one, or someone who had not a sterile OT conducted a C-section on them. So open wounds, open abdomen, really bad infections, sepsis, sometimes leading to death. So it's not, I think it needs to be done when it needs to be done, but it is also done when it doesn't need to be done. And then it just can't happen like that.
Oof. Yeah, I'm always really sort of rendered speechless when it comes to things like this, because these are all situations that have answers, and they're all situations that with the right kind of attention and monitoring and care can be prevented. And there are also so many factors that go into why women just don't have access to, so many women don't have access to that kind of safety to be able to do something that's so important. And we place a lot of emphasis on it culturally, and we pride ourselves on our family values, but at the same time we don't have infrastructures which make the existence of that family safe. Going off on a slight tangent here. Okay, one thing I'm also curious about, and maybe Neha, you can tell me a little bit about this, is RH incompatibility, because I realize that is also something which needs to be looked at. And again, it goes back to my original curiosity about planned pregnancies, because if you're going to have a baby, then there are a lot of other things that you need to consider to make sure that your baby and your pregnancy is a safe one. And I think RH compatibility does fall into that planning category.
Absolutely. So RH incompatibility is something I particularly feel strongly about, because I've seen, so what it is that if a woman who has a negative blood group and her partner has a positive blood group, and she gives birth to a baby with a positive blood group, if it's a first baby, it's all right. But if she doesn't get an anti-D immunoglobulin injection, a lot of times, even if it's just sometimes in miscarriages, we see this as well, if any of the blood transfer has happened between the mother and the baby, the mother's body starts having a immunological response to the pregnancy. So she'll start developing antibodies. And the next time she'll develop antibodies against it, it starts seeing it as a, alien host kind of thing.
Yeah.
Invader, exactly. So the next time, so that baby's born, that baby's fine. Yeah. The next time if she has a baby, which is again a positive, the body will attack the baby with antibodies, because the mother has antibodies. So sometimes it's not an issue, but I've seen women who've had one baby, didn't get an anti-D injection, and this we see a lot in Mama Baby Fund also, because the immunoglobulin, the anti-D injection is expensive. So a lot of times it's not offered. But if a DI does a delivery, she's not thinking about the blood group at all. She's not thinking about the anti-D. The anti-D costs 6,000 to 7,000 rupees. And I have in my career, never seen anti-Ds being given for free in anywhere. So a lot of times people will say, okay, when they don't understand the importance, it's not counsel. They'll say, okay, fine, I'll take. So
and like you said, a lot of women are unable to come back to the as well. So maybe now that they've had one safe delivery, they're like, we'll cross that bridge when we come to it, and then maybe just aren't able to bring it up again when it's next time.
So they may not, so anti-D can be given, at 28 weeks, 34 weeks, but also postpartum in the 72 hours, it can be given.
Okay.
But they may not have access or know about the issue. And because of that, I've seen multiple women who've had one healthy baby and then had maybe 5-6 losses after that.
Yes.
Or if they've had a baby, the baby's had either needed an exchange for complete blood transfusion for the baby when it's born, because it was born jaundiced, or had hydrops fetalis, which is not compatible with life, or just lost the baby in utero. So this is something that I don't think to a woman who comes to antenatal clinic in my midwifery clinic, she would not know about it. So it's something that I don't think that a lot of people have awareness about.
Absolutely. And a lot of people don't even know their own blood groups a lot of the times. And that goes across, I think, income and social advantages. Well, I'm afraid that we have run out of time, and this is a conversation I would like to keep on having, and maybe we'll continue. Thank you so much, Dr. Shahnaz, and thank you so much, Neha, for being with me today and for shedding light on so many crucial and important situations that can endanger the lives of women who are having babies, that can endanger the lives of said babies. Again, like I said earlier, we are a society and a culture that takes great pride in our wonderful children and in the family units that we create. But one crucial thing is that without a healthy mom, you can't have a healthy family. Yeah, I think it's as simple as that. Thank you so much for watching. If you're watching this on YouTube, don't forget to like and subscribe, and we will see you next time on the coffee table. Bye.